Hello everyone and welcome to the second dialogue workshop of the Horizon 2020 project SHAPES. SHAPES stands for Smart and Healthy Aging through People Engaging in Supportive Systems. It is the aim of the project to prepare the EU for the effects of demographic aging by providing a EU-wide and standardized platform that will provide user-centered digital solutions, services and information to support the aging population in Europe. My name is Philipp Franke and I work for the Germany-based company Carus Consilium Sachsen. We are one of 36 partners of the SHAPES project that come out of 14 different EU countries. I am also the coordinator of this event, and today I will be your guide through the program. Due to COVID-19, we decided to go for an online workshop to avoid any risk for infection. The first dialogue workshop, which we performed in May 2020, was also purely online and was very successful. Therefore, I'm sure that the event today will be very successful too. Importantly, the dialogue workshops are part of 8 dialogue workshops that will be run throughout the SHAPES project. The purpose of those dialogue workshops is to present the SHAPES results and validate them together with you. We want to openly discuss the results and the topics of SHAPES with you, the stakeholders of the SHAPES ecosystem. The event today is divided into 2 parts. The first part has already started here on YouTube with this stream. Later on, you will hear several talks here on YouTube. Afterwards, in the afternoon, you will engage in 4 interactive workshops run in 4 parallel sessions on the Zoom platform. For this, we divided you into 4 different groups. That way, each group can engage in each topic of the workshops. Shortly, we will start with the talks of the morning session. It's important to know for you that these talks were pre-recorded. So we invite you to ask any questions in the live comments on the right. The speakers that you will listen to are here with us now and are able to answer your questions. Additionally, if you have any problems that you should encounter, please don't hesitate to contact us via shapes@caruskonsilium.de. This email address is now provided in the comments section, and you can also find it in the description of this video below. The first talk that you will hear today will be provided by SHAPES leader Professor Mac McLachlan from the National University of Ireland. This talk will give you a more detailed introduction into the SHAPES project. Afterwards, Dr. Melanie Labour, also from the National University of Ireland, will focus on governance of health systems in chosen EU countries. This talk will serve as a basis for the subsequent interview that we prepared for you. In this interview, we will get answers from 3 of our pilot regions with the focus on integrated care. Those pilot regions are in Portugal, Greece and Northern Ireland. Afterwards, Professor Delia Ferry will guide your attention towards the future of EU health policies, considering lessons learned from the COVID-19 pandemic. Dr. Alexander Berler from Gnomon in Greece will conclude the morning session by giving an introduction to the SHAPES architecture and challenges for information exchange. After a short break of 10 minutes, we will gather here again and I will give you a short introduction into the 4 interactive workshops of the afternoon. Before we start with the talks of the morning session, I would like to thank everybody that was involved in preparing the event. I would like to thank the speakers for preparing their presentations and recording them, so we can enjoy them today. I would like to thank also the moderators of the interactive workshops for workshop preparation and later on for guiding the participants through the discussions. Last but not least, I would like to thank our partners at Age for preparing and advertising the event. For easy accessibility to the content today, we provide subtitles, international sign interpretation, as well as live transcripts during the interactive workshops. So thank you very much for joining the event today. I hope that you will find a lot of inspiration and that you will engage actively in the workshops later on. For now, I will hand over to Professor Meg McLachlan and Dr. Melanie Laber for the first talks. Please enjoy.
Good morning, everybody. My name is Mac McLachlan, and I'm presenting here on behalf of the coordination team, which is myself, Michael Cook, and Niamh Redmond, all from Maynooth University. It's a real pleasure to be part of this webinar, and I'd like to congratulate our colleagues, and I very much look forward to hearing others on this webinar, and then perhaps most importantly, in terms of others from outside the consortium who are joining us, we really look forward to hearing from all of you as well. And thank you for joining us. Okay, so I've said a brief welcome and also a brief thanks. And I'm going to talk about the scope of the SHAPES project, its aims, give it a little bit of an overview, and then talk about the progress that we've made so far. In terms of partners, we have 36 partners across really much of Europe, from both Northern and Western and Southern Europe, from a whole range of different sorts of contexts and a whole range of backgrounds. So we have a lot of small and medium enterprises, a good number of universities and civil society, non-governmental organizations. We also have public bodies, research organizations, and larger scale industry. So really a whole range of the stakeholders that are involved in smart and healthy aging. Understanding the life world of older people is the key to the SHAPES project. So this notion of smart and healthy aging, in terms of people being empowered through engaging in promoting systems, that's what SHAPES stands for. That is really bedded in the importance of understanding what is it like to live as an older person within Europe. And of course, it's not like any one thing, because the countries, the cultures, the infrastructures, the challenges that older people in Europe face differs hugely. And you'll see from the range of countries that we're in, we have a huge range of different contexts. So it's key for us to understand that life world and to hold up the differences in people's experiences as being a key to how they can age well. So understanding the context and making sure that within their context that we can have age-friendly physical and social spaces and pathways, and that they are truly empowered to make decisions that relate to achieving their own goals and enhancing their own quality of life. In terms of an overview, we want to look at how current and future digital solutions and innovations support planning for extended lifespans while maintaining independent, healthy, and active lifestyles. So it's not digital solutions for their own sake. It's the active and healthy lifestyles and the independence of living are all key parts of extending lifespan. That's what it's for, and the technology is a means, not the only means, but one means of helping us achieve that. So part of that mission, if you like, is to develop an integrated care platform, which means that we can bring together lots of different digital solutions. And we will be trying out many different types of digital solutions from apps that you might use on your phone, to sensors in people's homes, to robotics, to different forms of artificial intelligence, identifying key types of information that help people make decisions, and so on. So the platform seeks to bring those all together to interact, if you like, in the same digital space. In other words, to be able to talk to each other and have a sensible conversation. And that ecosystem that I was mentioning before is therefore central, in that different places in Europe have different sorts of infrastructure. I'm talking to you now from Westmeath in the rural countryside of Ireland. We have pretty awful internet connectivity here. So there's various things on my computer that I'm speaking to you on here, various applications that I can't run simply because I don't have the bandwidth that would allow me to. This is just one example of how the resources that we have in different parts of Europe vary greatly. And the content of what might be appropriate in rural Ireland might be very different from what might be appropriate in Olomouc or in Berlin or anywhere in Europe. Now, in the same way, the European marketplace is a very broad area, the largest marketplace in the world. And it's incredibly important that we can stimulate innovation and productivity within the different small and medium enterprises and large-scale industry within Europe. However, it's also equally important that when we do that, we're doing it in a socially responsible way. And so another way in which Shapes interfaces with the marketplace is through what people call market shaping. And market shaping is ensuring that the innovation and good industrial activity doesn't just go towards areas that there's high profit returns on, but also engages with areas where perhaps traditionally there have been lower returns. So we can seek to bundle high return activities with perhaps lower return activities, with the basic aim to make sure that nobody is left behind in terms of achieving the benefits of digital and assistive technologies. To ensure that that becomes a reality, we're going to develop not just guidelines, but a roadmap to actually make sure that it happens, and an action plan for implementing that roadmap. So again, as an overview, you can see here that we're looking at the Shapes platform bringing together at the top, yellow, I have a diagram which is showing how the home feeds into the Shapes platform. I also have a diagram that looks at how behavior at the individual, community and healthcare level can feed into the Shapes platform. And I have another arrow coming in from below, looking at how market-based activities we've just been discussing can feed into the Shapes platform. And then finally, a fourth arrow that looks at the really important issues around governance. How are the systems, policies, and laws going to interact to provide appropriate standards, and to do so in an ethical framework that protects individuals' confidentiality, their security online, and make sure that people can trust this platform to do right by them and to provide information that's going to help, and not to leak information that would be a worry to them. So we take that incredibly seriously. If we don't have a platform that people trust, then people simply won't use it. So I think the ethical and standards element are a bedrock of what we seek to do. So the next slide shows a couple of diagrams One in particular relating to what people refer to as wearables. So in this case, there's a woman who's wearing sensors. These sensors could look at vital signs. So for instance, it may be cardiovascular function, respiratory rate, temperature. It's not necessarily the case that people would be wearing these all the time, but if they're having a period of feeling unwell, then it can be very useful to have these measurements, allowing people to stay at home, engage in their community, engage in their usual activities, interacting with family and neighbors, rather than going into hospital to have these sorts of assessments taken and moving them out of their community context. And on the right-hand side of my slide here, I have it's really illustrating a range of different information for caregivers, care service providers, health providers, policymakers, researchers, and analysts, bringing all of this information together into one platform, and most importantly, making it usable, not just for healthcare workers, but very importantly, for the older person themselves. So making it accessible, usable, understandable, and relevant to their own goals in their own life. So with these big ambitions, what we have decided to do is to have certain pilot themes. So these are areas of particular focused interest that we want to we want to develop in order to see how we can bring together all these different sorts of technologies and make sure that they add value to this sort of ecology that people live in and their broader social and resource context. So these pilot themes are to do with smart living environments in the home. They're also to do with community-based services and how they interact with the home, how medicines can be optimized again from the home setting with strong professional support from outside the home. They look at psychosocial and cognitive stimulation whilst people are living at home. Caring for older individuals with particular types of disorders will also be an interest of the project. And one of these is looking at neurodegenerative diseases. And then across a whole range of diseases or disorders, of course, the importance of physical rehabilitation, again, in the home environment. And it's not all in the home, because we're very aware that many older people want to travel across European borders. And so it's really important that when you travel, you can bring with you that whole knowledge base that exists around your interests and desires, but also around some of your medical and health needs. So it's not like when you travel, you leave those all behind somewhere. They're all available. For instance, if you need to go and see a GP when you're on holiday in a different country, that GP general practitioner can also have access to the sort of information that this platform will provide. Okay, so progress to date for the project. To be honest, I think given the difficulties of the situation that we're living in, and I'll say a little bit more about that in a moment, I think we have been very good at keeping up to pace with the program deliverables. And I know on behalf of the coordinating team, I'd just like to say how grateful we are to everybody, because we know it's not easy. Many people are working at home. Very sadly, some of us may have lost loved ones, and others of us I know have been personally affected by contracting the COVID-19 virus. So these are all very demanding situations, and we're really grateful that people, despite this, have done their best to keep the tempo of the project, to keep it moving along at a good pace. The project started in November. As you can see from the table here, we've had deliverables from work packages 1, 6, 8, 10, and 11. So many of these are fully complete. Some of them are uploaded and still awaiting some small additions. That is perfectly okay. We want to maintain the momentum, but we also want to be realistic and flexible around what people can possibly do. But just to say again, thank you to those in the consortium for keeping the tempo going. So something about SHAPES and the COVID-19 situation. Of course, this is a huge human tragedy. And it's also a huge public health systems challenge right now as we speak. It is happening, of course. And as I've mentioned, it's a challenge for progressing our work. But it's also an opportunity to support people and systems in real time and to learn from the sort of experiences that we're having now from a broad range of stakeholders. And that's why it's really important, and we're so grateful that it's not just members of our consortium who will be attending and are attending this webinar, but the wider public and different interest groups as well. And we really do want to hear from you. We want to hear in particularly things that we're doing that maybe aren't right, things that we could do them better, or new ways of doing things that we may not have considered. So I think COVID, it doesn't just offer an opportunity for the future, it really presents us with an obligation. COVID will, of course, in time pass. There may be other viral epidemics, but there will certainly be other public health challenges. And so it's going to be really important that smart and healthy aging is prepared to respond to these challenges through systems like the sort of platform that SHAPES is going to provide. So I think there's a real opportunity to think into the future, and I know that's going to be part of some of the work this afternoon in thinking more broadly about the work of SHAPES, but also taking into account some of the challenges around COVID-19. So let me just conclude by thanking you all very much for your time listening. And from the coordinating group for SHAPES at Maynooth University, again, a big thank you to the organisers, and we very much look forward to listening to others and to participating in this webinar. Thanks very much.
Hello, my name is Melanie Labor. I am part of the psychology department at Maynooth University, and I've been working on the SHAPES project as a postdoctoral researcher. Today, I'll be talking about the topic of governance in relation to European health systems, which is a very small portion of the overall work. But before I start talking about governance, I will give you an overview of the part of our work that is relevant to governance, as well as to the topic of this workshop, which is on integrated care models. As part of SHAPES, we have been mapping healthcare models in European countries. We have been doing this by exploring the organizational, structural, and systemic factors of healthcare systems, which also includes human factors. So this work has resulted in a so-called concept of operations, or Conops. The Conops has several functions. It is a guide for the development of the SHAPES platform. It helps us to capture the range of contextual factors that make up the organizational ecosystem of healthcare provision. It allows us to survey the range of organizational models and to see how precisely SHAPES might fit in among these existing systems. It helps us to imagine and specify the future operational situation with the platform to support evaluation. It also gives us a set of heuristics to help us not to lose sight of the overall purpose of the platform. And my last point is that Conops is a human activity-centered framework, which means that to construct the Conops, we have consulted with a range of stakeholders involved in healthcare provision. And at the moment, the Conops is still evolving and it will be guiding the platform development process. To map different healthcare models in Europe and to create the Conops, we interviewed Shape's partners involved in healthcare and asked them a range of key questions. And those questions are: who are the stakeholders involved in the system? We asked why, which means what does your organization lack that the system will provide? So in relation to Shapes, we're asking, what do healthcare systems lack at the moment and what can Shapes bring to the table? We asked what are the known elements and the high-level capabilities of the system. We also asked what is the time sequence of the activities that will be performed. We asked what the geographical and physical locations of the system is, and in relation to Shapes, we basically asked for a description of the geographical and physical locations of the pilot sites. And lastly, we asked what resources do we need to design and build the new system, which means the Shapes platform. So the Conops we developed for Shapes has the following components. We are giving a description of the pilot sites, its health context, and also a description of the health system. We are describing how health and social care is currently provided. We looked at the care pathways into and out of institutional care and at the criteria that need to be fulfilled to allow an older person to return back home, which is really important because we are looking at facilitating independent living for as long as possible. We also gathered information on the technologies that are currently used at the participating sites, and we looked at the human factors, which refers to how individual traits, the workplace environment, and management procedures impact on the healthcare system as a whole. Other components are the regulatory, legal, and ethical context, the limitations, constraints, and risks associated with each healthcare system, and lastly, the changes that are necessary to improve the system. I would now like to look at one component of the Conops in a little more detail. So when we looked at how healthcare systems work, we also examined the structure of each system, its organization, and how responsibilities are divided, which refers to the governance of the healthcare system. We are using the World Bank's definition of governance, which is the process and institutions through which decisions are made and authority in a country it is exercised. So you might ask why it is important to look at governance during a workshop on integrated care provision. Well, understanding how different healthcare systems are governed can help us to improve the continuity of integrated care and the sustainability of health and care systems across Europe. So in the coming months, we will be continuing our work on governance to establish the Shapes governance model and guidelines, which are intended to support and extend active aging and independent living of older people. For this task, we are interested in two questions. The first looks at how health systems in Europe are governed in terms of their structure and division of responsibilities. The second asks how and to what extent can healthcare receivers make decisions about the care that they receive. We have already collected some data on the organization and division of responsibilities in selected countries. In healthcare provision, there has been a trend towards the decentralization of health systems, and some countries have much more decentralized systems than others. For example, Cyprus has a highly centralized system and decisions are predominantly made by the central government. On the other hand, Germany, Italy, Spain, and the UK take a very decentralized approach, which means that structures and responsibilities are much more divided and different decisions are made at national, regional, and local level. There are some differences between those countries. Germany, for example, is a federal state, which means there is no central government as such. Italy, Spain, and the UK, on the other hand, are unitary states with a central government, but these countries still take a decentralized approach to healthcare provision. There are also a range of partially decentralized countries such as Czechia, Greece, Ireland, and Portugal, which are neither fully centralized or fully decentralized. I'd like to give two examples of the organization of health systems. One is an illustration of the Cypriot system. Cyprus has been taking steps to unify their healthcare system, which used to be highly fragmented with poor coordination between the public and the private sector. Today, Cyprus has a general healthcare system, and the overall responsibility is concentrated within the Ministry of Health. There are two organizations that answer to the Ministry of Health. One is the State Health Services Organization, which is responsible for the development, management, control, and supervision of public hospitals and health centers, as well as for the provision of healthcare services. The other is the Health Insurance Organization, which is responsible for the purchasing of healthcare services from both the public and the private sectors. The other example is of the German healthcare system, which is based on the principle of self-governance, which means that institutions at the national and regional level have different responsibilities. The Federal Ministry of Health is responsible for the development of laws, healthcare policies, and administrative guidelines. The federal states are responsible for hospital planning and the allocation of funding for hospital investments. There are also self-governing bodies, which include associations of sickness funds, healthcare providers, and the German Hospital Federation, which form the Federal Joint Committee. This committee is responsible for formulating specific regulations that are based on the statutory goals defined by the Federal Ministry of Health. And these regulations become legally binding directives that are issued to all actors within the health system, such as healthcare providers, purchasers of healthcare, patients, and manufacturers. Although the entities at the different levels are self-governing, they still interact with each other. For example, the Federal Ministry of Health can object to the regulations drafted by the Federal Joint Committee, but in essence, the German health system is highly decentralized. So we have a relatively good overview of models of healthcare provision in terms of governance, but we are still missing information on the second question on how and to what extent healthcare receivers can make decisions about the care that they receive. And this is a very important part of the SHAPES project, as its overall goal is to enable older people to live actively and independently. And the integration of health systems is also very much dependent on an understanding of healthcare systems are currently governed. So we hope that some of this information will come out of the conversations that we will be having today. So thank you very much for listening and enjoy the workshop. Thank you.
Thank you very much, Professor McLaughlin, for the overview about the SHAPES project. And thank you, Dr. Melanie Leber, for the talk about governance of health systems in chosen European countries. This last talk serves as the basis for the now following interview that we prepared for you with 3 experts from 3 different SHAPES pilot regions. With us now are Professor Michael Scott, the Director of the Medicines Optimization Innovation Center in Northern Ireland, Dr. Pedro Rocha, a researcher at ICBAS Porto in Portugal, and Dr. Rania Pinaka from the 5th Regional Health Authority in Thessaly and Styria in Greece. We asked those 3 experts 5 questions considering integrated care and asked for their region-specific answers. The first question for our experts is, can you please classify your regional health and care systems within the governance models that we just heard about in the last talk?
Okay, in Northern Ireland, the funding comes from the UK government, via the Barnett formula, which is based on the population needs. This funding then for all local government is made available in our case to the Department of Health, and they're responsible for all regulations, legislation, guidelines, implementing National Institute of Clinical Excellence guidelines and emergency planning. They then allocate funding to the Health and Social Care Board, who will then commission services to meet the population needs. This is largely done via the 6 trusts, which are legal entities. They provide health and social care, and they have to provide a delivery plan to meet the board's commission and the department's requirements for each financial year. In addition, there are GP and community pharmacist contracts and services negotiated by the board with the representatives of both of those bodies, and they provide basic core service and enhanced services. 2 other entities are the Public Health Agency, which is devoted to health prevention and promotion, including vaccination and health screening, and the Regulatory Quality Improvement Agency, the RQIA, which carries out inspectors to meet standards. One other key body is the Patient and Client Council, representing our patients and service users. And finally, we have care homes, both residential and nursing, which are linked to both private and the public sector, covering our governance for health and social care.
In Portugal, healthcare system and social care system are national centralized on their lead ministers and respective regional delegations. Each regional delegation represents the national politics level on regional level, but also they represent the regional needs and interests on national level. While the governance of healthcare system is structured by a national health system, the social care governance is structured by the National Institute of Social Security. These national institutions are responsible for observing the applicable norms, regulations, standards, and public funds. Nevertheless, both systems, especially the social care system, have been established protocols with other public and private sectors, health, universities, research, insurance companies, education, to improve and to increase the healthcare and social care delivery and their positive impacts.
The Greek health system is characterized as mixed and is based mainly on compulsory insurance. The Greek system is characterized as mixed because part of the funding comes from insurance contributions and another part, mainly at the level of hospital care, from taxation. There is also an increased involvement of the private sector in both the provision and financing of health services.
Thank you very much. Our next question is, which institutions or stakeholders are the primary driver to push innovative integrated care models in your region?
Okay, in terms of integrated care models, the main driver is the Department of Health here, which is responsible for health and social care in Northern Ireland and are very driven towards achieving an integrated care model. In relation to that, a key document is the Ben-Goa report, which the government commissioned here, which is entitled Systems, Not Structures. This is about building a system around patients, not around buildings and facilities. This is ideal for an integrated care model as it brings in patient-centered focus, being participative, based on population needs, based on predictive analytics, and also being effective. So it actually achieves a triple aim by integrating all aspects of care, from independent contractors to trusts to community-involved settings. In this regard, then, the government has set up multidisciplinary team pilots in 2 regions in Northern Ireland, bringing together all of the key stakeholders, like healthcare professionals, nursing, medical, independent contractors, in pilots to be assessed. A classic example now, this is the Northern Area Prototype, which is established a local accountable organisation chaired jointly by GP Federation and the trust in the area, and bringing together all stakeholders to create one forum to look at the needs of the population and then to decide on how that can best be met by bringing together all of the assets. And that enables the integration, and as Northern Ireland is an integrated system already with health and social care, it brings in all social aspects. as well as health to achieve the goals of a healthy ageing population, which is a key driver for the department, being a reference site for the active and healthy ageing on the European Innovation Partnership linked to medicines.
In metropolitan area of Porto, our region, there is no specific primary driver to push innovative integrated care models. What exists since 2006 is a national network of integrated continuous care launched by the Portuguese government for all the country. This network provides continuous integrated care for dependent people for all generations and ages, and long-term care in whole country. More or less, all units from this network are composed by hospitalization units, especially for palliative care, outpatient care to promote autonomy and independent life, and a multidisciplinary team composed by health and social professionals who work in hospital and in home or community. Nevertheless, metropolitan area of Porto is a territory where lives around 2,000 million persons, distributed by 17 municipalities, and where there are 40 hospitals, 300 primary care centers, 25 centers of continuous integrated care, and around 700 social care organizations for take care holder individuals. In this territory, the municipalities have been deployment local and regional initiatives such as planning and financing of health and care delivery and organization, and the social sector, supported sometimes by the municipalities, from ONGs or single social entrepreneurs, have been created startups or communitarian-based projects which integrate health and social organizations and delivery.
The participating services involved and related to promote and develop an integrated network of services that will focus on the health and social needs of the people are the Health Region, 5th IPE, responsible for the interconnection of healthcare structures with primary healthcare and secondary healthcare, the local authorities, municipal services with medical and social structures such as help at home, social clinic, social grocery, social pharmacy, the Roma Community Center, the Estia program for refugees, also the regional authorities with social care structures such as nursing homes, day center for people with Alzheimer's disease, residential houses for older people with mental health problems, the Creative Employment Center. Last but not least, the primary healthcare units and general practitioners in urban and rural regions.
Thank you very much for this valuable insight. Can you now please tell us about one major success story of integrated care in your region? What were the key success factors?
One major example of success would be within the Northern Area Prototype area, working with the Mid and East Antrim Age Well Partnership. And that's a local interagency-based partnership aimed at improving the lives of older people over 60 years of age and living within the locality. This was funded by the Dunhill Medical Trust as an initial pilot 5 years ago, and has now been successfully received funding for a further 5 years. It's very much a user-centered approach for older citizens, looking at what they need and what matters to them is the key driver for work that is undertaken within the partnership. A significant community and voluntary group involvement, and that has worked extremely well, particularly in COVID, which has enabled us to access assistance for older citizens relevant to their particular needs. It includes the Healthcare Trust, which, as we've said, is a combined acute and community trust, so there's acute facilities and surgery, unscheduled care, etc., but also a wide range of community facilities based in health and care centres, incorporating general practitioners, social workers, dietitians, podiatrists. And that allows a great range of services to be provided in an integrated fashion. The value also is bringing in independent contractors, namely our general practitioners and our community pharmacists, as they typically act as independent contractors, but within an overall commissioned plan from our commissioning board, the Health and Social Care Board. This has proven extremely valuable as they have actually created hubs within the community, linking the general practitioner, but much more recently the community pharmacist into the multidisciplinary team to bring that expertise. And that has worked extremely well. Another key success factor for this is the establishment of robust metrics at the start of the original piece of work to look at the social care impact of the model on all aspects of patient care, and also a robust impact on the medicines aspect, as the community pharmacy involvement was very novel. So these robust metrics then allow scrutiny of what has been achieved, and therefore allows the opportunity to scale and spread further based on the learning from the pilot. This has been successful as originally carried out within 15 areas within the trust area. That's now going to be increased to 26 over the next 5 years, and then with hopefully a parallel spread to other parts of the province, building on the success. The group has also expanded its membership and will hopefully scope with other areas in the province.
In metropolitan area of Porto, the ULS Matosinhos is a major success case of integrated care. She is a health local unity that provides a wide range of health and care services: primary care, hospitalizations, integrated care, medical appointments, clinical services, diagnostic services, public health unit, clinical trial centers, and social assistance. One of the major successes of ULS Matosinhos is being a model for other national ULSs, and according to its president, António Taveira Gomes, there are 6 factors that can explain the success of ULS Matosinhos: health promotion through a holistic, integrated, and personalized approach, engagement of all local authorities, community, families, and individuals, integration, sustainability, training, differentiation, trust in human resources, and invest in certification of quality, scientific and technological research and development, and innovation projects, digitalization, e-health, and ICT skills. Moreover, it's critical to highlight the role of University of Porto in this process of innovation, especially promoted by some organic units. The first one is Porto for Aging, which is a regional network from Porto that includes companies, social and health organizations, decision makers, universities, municipalities, etc. And Porto for Aging is a Hyponaha replicate site with 4 stars. University of Porto is also a RIS hub of IT health, and she have an incubator called UPTech, and both are working in the last years to integrate e-health solutions in integrated care. The last organic unit is the research group Synthesis Agency, which are working with which are producing a multidisciplinary knowledge and social innovation that are able to innovate the integrated care provided by health organizations, but also social organizations which work with older individuals.
The opening of new primary healthcare units on December 2017 was an effort towards establishing modern, people-centered primary healthcare services in Greece. The primary healthcare units, called Topικές Μονάδες Υγείας, TOMI in Greek, are key elements of the newly designed primary healthcare system and serve as the first point of contact and the main coordinator of care for people in the area. Multidisciplinary teams, general practitioners, family doctors, pediatricians, nurses, health visitors, and social workers will provide health care for people in a continuous manner, looking at disease prevention, health promotion, diagnosis, treatment, monitoring, and care. The new units try to have clear referral mechanisms, This is a major change from the otherwise fragmented network of different public and private health providers, primarily specialists, providing care upon request and with little coordination. The key success factors are patient-centered care on the individual, his family and his preferences, integrated care, prevention and promotion of mental and physical health, medication management, treatment and rehabilitation, coordinated care, specialists, hospitals, community services, accessibility to care, minimization of waiting time, telephone and electronic communication.
There is no doubt that these stories show us the importance of integrated care, which brings us to our fourth question. What is the key challenge for establishing integrated care in your region? Can you please elaborate on the reasons?
In terms of establishing integrated care, financing obviously is a key issue. However, the overarching accountability infrastructure is the other major problem. You need a very robust governance structure. You have a large number of different participants in what is required to deliver a fully integrated care system, but there must be accountability in terms of potential problems, system change, etc. And that needs to be robustly built in and have appropriate corporate governance structure, incorporating risk management, risk registers, decision making. This is critical because a lot of the work in terms of care pathway redesign, current systems are suboptimal, they don't meet fully patient needs, and they're wasteful of resource right across the whole spectrum of both health and social care. So care pathway redesign takes a lot of time, and there may be a lot of conflicts to be resolved in terms of eliminating duplication and what people have previously been doing. So you need a very robust change process, engaging all stakeholders, and ideally use some form of quality improvement methodology based on the International Healthcare Institute type of work, where you'd have small-scale tests of change using PDSA cycles. That allows everyone to fully engage in the process and get ownership of that, and that's very, very important. In addition, we've looked at health and social care. However, it needs to cover right across all government departments, and that is an even bigger challenge. So you bring in Department of Economy and Department of Leisure activities, etc., because all of these are interlinked in a robust social prescribing model that provides preventative and health developing in the first instance. And that's particularly challenging as it relates back to finance, but also governance is much more difficult to do with multiple departments involved.
Among all challenges, the quality of social assistance, integration of e-health solutions, professional training, holistic approach, communication between health and care providers, population aging is now a key challenge for establishing integrated care in metropolitan area of Porto, but also in Portugal as a whole. According to the National Network of Integrated Continuous Care, despite this model have been designed for all patients, indeed around 85% of their patients are older individuals, more than 65 years old. Numbers from 2015. There are two main reasons for this challenge, one demographic and the other paradigmatic. On the one hand, this number means that older individuals are being the main population target for integrated care, with different impacts for health and care delivery and services, new medical and social cultural approaches, therapeutics, knowledge and innovations, suitable care infrastructures and environments, new professional skills, links between hospital, home and community, and others. On the other hand, the number also means that Portuguese integrated care model is not replacing the oldest model of health and social care, which is fragmented, national centralized, and distant of their stakeholders, micro, meso, and macro. In this regard, it's not only population aging, but also the time of our paradigmatic change. We will need time and political effort for improved organizational and management models and behavior and improve also the behaviors and the mentalities.
The organizational and functional reconstruction of primary health care is the key to integrated health care. Organizational reconstruction of primary health care includes increase of human resources working in the primary health care, networking and interconnection of institutions and organizations, cooperations of health professionals in the context of primary health care, building up a network of health and social services. The functional reconstruction includes organization of a unified system of coordination, administration, and supervision of administrative work, training of the human resources working in the primary health care, study of the needs of the population of responsibility.
Thank you for highlighting these challenges that we surely have to consider within the SHAPES project. As the final question of this interview, I would like you to elaborate on this. Should the EU play a role in ensuring the establishment of integrated care across all EU member states?
In terms of whether the EU requires a role or needs a role in integrated care, I think the answer has to be yes. It is very important to have a policy-led imperative, as that it enables drivers to be put in place that allow the government to achieve that goal. So with a policy imperative set at the EU level, then governments will be encouraged or indeed mandated to sign up to this approach. And that, again, it will allow governments to set policy, which then allows their different providers, be it health institutions, social care institutions, any sector within that, to formulate plans to meet the government sign-up, to meet the EU policy imperative. The value of this is in terms of ensuring a standardisation of evidence-based best practice that will allow great commonality across all the regions and not have a variety of different solutions that are not interoperable or indeed transferable because of how they were set up. So that degree of interoperability will allow a robust evidence-based practice to ensure older citizens get the same level of care right across the whole spectrum of the EU. And that must be fully evidence-based, and that can be achieved by using tools such as MAFIP, and also usually momentum and mass, where you're bringing technology to enable care, which is very important in terms of achieving optimization and effectiveness in financially constrained times. In terms of the EU, I think it's important that all directorates are signed up with that, not only DG Sante, but also DG Connect, for example, giving the significant importance of the digital innovations and the efficiencies and better patient care that can be achieved, particularly with older citizens over that time. And that requires a greater degree of health literacy and technical literacy. And therefore, by using all the relevant directorates available within the EU, then this can be achieved. In addition, there should be robust metrics developed, and therefore at Europe 2027, there should be key funding components put in place to achieve and evaluate some of the practices that are currently there and enable us to get an appropriate baseline, put in place those aspects that have been shown to be of value in different countries. And for example, work done by the EIP on AHA. A lot of work has been done within that environment, both by the reference sites and the action groups, and those should be built upon and then rolled out where they have delivered significant improvements to the system. So in conclusion, I think the EU has a key role. So it starts at that very, very top level. That filters down to government level, who then should be setting their action plans and delivery plans with all of their providers right across the system, be they public, as in the UK, and also in the private sector, and would need to involve health insurance organisations, given the different structures. All of those folks have a role to play in achieving the integrated care.
For this question, I have two different answers. The first is no. It's not necessary to create a EU-based governance only for the integrated care. In a very strict academic perspective, the concept of integrated care presumes different and independent domains, which must be connected for a specific purpose, social and health delivery. And in European Union already have governances for each one of these domains: health, social affairs, humanitarian causes, technology, education, culture, market, leisure, and others. Moreover, integrated care is not a single domain, but a galaxy composed by parts of several domains. The second answer is really yes. What we know now is in coming years, healthcare and social care will be an effective part of European growth and competitiveness by two ways. First, Europe as an active territory which improve well-being and quality of life for all European populations. Indeed, despite the economic and financial power of other global regions, for example, USA, the qualified professionals now find a health and active lifestyle and environment, which is possible in Europe. Second, Europe will be an active investor in new innovations and knowledge for establishing and regulating as well the integrated care models from European member states. In conclusion, despite the well-known differences between European member states, the role of the European Union is also to provide for each member state similar guidelines, regulations found in several domains, integrated care as well. If these guidelines and if this support improve the well-being and the quality of life for European populations and the sustainability of state members from Europe.
It is widely recognized that the reorientation of healthcare services from hospital-based to community-based care requires integration between social and healthcare institutions and organizations. Although integrated care has been under implementation in some European countries, it is a relatively new concept for others. Despite the fact that integration models having a similar background, it cannot be argued that there is a European consensus about the concept of integrated care. For some, it means the whole health system restructuring. For others, the improvement of relations between parts of the system, health and social care, or acute and primary care, and for others, it means a partnership between providers, organizations, and professionals. In Greece, a first attempt was made. Two cities were proposed, Ioannina and Larissa. Experts from WHO Europe and the Greek Ministry of Health discussed the piloting of integrated services at a local policy dialogue in Ioannina on October 2017. The policy dialogue included key stakeholders from health and social services, the city's university, and local authorities. The policy dialogue was organized under the second phase of the Strengthening Capacity for Universal Coverage initiative. To compare and better understand integrated care programs, definitions must be used and discussed, and interventions must be described. Being able to recognize differences between countries and interventions will allow a better comprehension of the international options available and a structured approach to analyzing the effectiveness of the programs.
Thank you very much to our experts for this interview and a brief comparison of these three SHAPES regions. As you can see, there are major differences between those regions when it comes to integrated care. SHAPES has to consider all peculiarities of regional differences and health systems in order to ensure sustainability for its platform and services. I am sure that this interview inspired you for the interactive workshops later on. For now, however, we provide you with two more very interesting talks. Professor Ferry will elaborate on the future of EU health policies considering lessons learned from the COVID-19 pandemic. Later on, Dr. Alexander Berler will conclude the morning session with a talk on the SHAPES architecture and challenges for information exchange.
Hi everyone, my name is Delia Ferri and I'm a professor of law at Maynooth University in Ireland. In the SHAPES project, together with my colleague Emma McEvoy, I conducted research in order to understand what regulatory framework can better support the SHAPES solution and the pan-European approach to healthcare. Today, I want to speak to you about the future of EU health policies and what lessons can be learned from the COVID-19 pandemic. My presentation is quite short, it's only 10 minutes, and I will address three main issues. First of all, I will sketch out the scope of EU health competencies. I will then address the core tenets of EU health law and policy. Finally, I will look at the role that the European Union has played in fighting the COVID-19 and what lesson can be learned from the action that the EU has taken. Let's get started. Well, first of all, the protection of health features in the constitutional framework of the European Union. Article 3, paragraph 1 of the Treaty on the European Union states that the Union aim is to promote peace, its values, and the well-being of its peoples. The reference to well-being has been considered as a broad reference to the protection of health of EU peoples. Article 9 of the Treaty on the Functioning of the European Union provides a cross-cutting provision that requires the EU to take into account the protection of human health when implementing all its policies and action. This is reiterated by Article 35 of the Charter of Fundamental Rights of the European Union. This provision not only states the right of access to preventive health care and right to benefit from medical treatment, but also states that a high level of human health protection shall be ensured in the definition and implementation of all EU policies and activities. In spite of this, the EU health competencies are quite limited. The EU has competence only to carry out actions to support, coordinate, or supplement the actions of the member states with regard to the protection and improvement of human health. This is established by Article 6 of the Treaty on the Functioning of the European Union. Article 168 governs the EU action on health matters and reiterates the role that the European Union has in supporting member states' action. It also makes clear that the Union action shall respect the responsibilities of the member states for the definition of their health policy and the organization and delivery of health services and medical care. The member states are hence the primary responsible subject for the organization and delivery of healthcare. In spite of limited competencies, the EU has progressively developed a union health law and policy, and according to several scholars, in particular Greer, EU health policy has three phases. There is an explicit health policy, there is an internal market policy, and there is fiscal governance that impacts on the way in which member states organize their healthcare system. In these 10 minutes, I'm not able to address each of these three phases, and I limit myself to recall that the internal market policy is quite important. And in fact, the most important piece of legislation on health, which is the Patients' Rights Directive, is an internal market instrument. It's based on Article 114 of the Treaty on the Functioning of the European Union. This directive sets out the condition under which a person may travel to another EU member state to receive medical care and reimbursement. If we look at current EU health policies, well, we see that EU health policy was not a priority for the Commission until 2019, so the Juncker Commission didn't really pay too much attention to health, but clearly the situation has dramatically changed since March 2020, and health and health policy have become a priority for the new Commission led by Ursula von der Leyen. The Commission has proposed a new standalone health programme for the period 2021-2027 called the EU for Health Programme. This programme has an overarching objective, which is that of strengthening the health systems of the member states. And the Commission proposes to invest 9.4 billion euro in order to strengthen the health system. Notably, within this program, the Commission aims to improve and to support the digitalization of healthcare systems, but also to improve the coordination among the member states and to support a better coordinated responses to future health crises. The European Union has so far resorted to several and different instruments in order to fight the COVID-19 pandemic. Many policy instruments have been used, but also the EU has resorted to different types of policies in order to fight the consequences of the virus. Well, first of all, the EU decisions on serious cross-border threats to health has been used in order, for instance, to procure medical devices or medicines at the EU level. So the joint procurement agreements that are provided for in this decision have been used in order to increase the supply of necessary medical tools across the European Union. State aid rules have also been extremely important in that they've been applied by the Commission in a way that has allowed member states to subsidize, to support the production of improved vaccine, the production of medicinal products, medical devices, medical equipment, PPE, disinfectants, but also have allowed member states to support the improvement of testing facilities. The use of the EU civil protection mechanism has also been very important in order to strengthen the collaboration among the member states and to support those member states that faced peak in the virus. The EU contracts to secure vaccine are also an important part of a coordinated response, of a pan-European response to the virus. The EU strategy for COVID-19 vaccine has been enacted by the Commission, and the Commission has signed the first contract with AstraZeneca to secure a vaccine, the purchase of a vaccine when it will be ready. This contract was signed on the 27th of August 2020. In spite of the use of these differentiated tools and the search for a coordinated response, there are still a lot of issues. Still, there is a lack of coordination among the member states when it comes to common risk criteria. There is no common modality for counting case. There is no common cross-border testing strategy. There is no common protocol for monitoring asymptomatic patients. These issues were highlighted by several MEP. One of those was Dacian Solos on the 2nd of September 2020. The European Centre for Disease Prevention and Control said that the priority should be given to the harmonization of test capacities and methodologies. So also the ECDPC emphasized the need of a better coordination when it comes to testing and diagnosis. The free movement has been fundamentally and dramatically undermined by movement restrictions that have been imposed in a scattered way by member states. The Commission has recently proposed a Council recommendation. This was issued on the 4th of September 2020, and hopefully it will be passed soon, in order to coordinate a better response in this respect and to limit the undermining of the free movement of EU citizens. There's been no attempt to create a European Union-wide digital tool, and there's also an important gap that has been highlighted. Each member state is taking its own approach. From what has been done and what has not been done yet, we learned that it's important to adopt a pan-European approach That respect for subsidiarity is key, but yet there is the need of coordination and solidarity across the member states. We also understand that the protection of fundamental rights of EU citizens, including the fundamental rights of free movement, must be at the forefront of every action. The SHAPES integrated care platform will offer a possibility to increase and to support a pan-European approach and to create a better coordination among healthcare systems across the European Union. The SHAPES marketplace can also contribute to match supply and demand when it comes to digital tools that can support access to healthcare for everyone and in particular for vulnerable people. All these issues will be discussed in the SHAPES project. If you want to know more about the topics that I have addressed, in particular EU health competencies, EU health policies, here are some readings that I suggest from several notable legal scholars. And I hope to see you soon in Maynooth in Ireland when the pandemic will be over. Thank you very much for your attention. If you have any question, feel free to write me.
Hello, my name is Alexander Berler. I am the Director at Consulting Services of Gnome Informatics, and I will talk about the SHAPES high-level architecture and the information exchange challenges related to that. So some initial words about SHAPES as a program. So SHAPES, it's an innovation action. It is a large-scale pilot to be deployed around Europe. And the idea is to create an EU standardized, open and interoperable healthcare platform. It will integrate a broad range of technological and other solutions in order to facilitate the long-term healthy and active aging and the maintenance of a high-quality standard of life. It will engage more than 2,000 older individuals in 15 pilots in 10 EU member states. It will include 6 reference sites of the European Innovation Partnership on active and healthy aging. There are 4 main components in the project. It's the SHAPES digital solutions, several different solutions about Internet of Things, robots, and others will be included. SHAPES will create an ecosystem of relevant applications and an ecosystem of participants within the project. SHAPES will create a marketplace so that several solutions could be included, connected, and integrated with the SHAPES platform. And it will also propose some recommendations, some guidelines about standardization and interoperability included. So there are 4 basic components in the 4 factors in this platform. It's the home, the behavior, the market, and the governance. So those 4 are the basic of the design of the platform, and also the need to create a first set of specifications that will be replicated and used for the architecture of the platform. So as you can see in this slide, the first 2, the home parameter and the behavior parameter, are concerning the functional requirements, while the market and the governance concern other non-functional requirements related to the market structure or some legal and ethical aspects. All these are backed up through the work packages of the program so that we ensure that everything is well analyzed for this. During the process of creating the specifications, we have identified 5 requirement dimensions and 6 actors groups that have been defined. So concerning the requirements, there are the dimensions. They are the functional, the legal and ethical, the technical, the security, and the business. While concerning the actors, we have the care receivers, the caregiver, a formal caregiver. We have also the informal caregiver. We have the healthcare professional, the social care professionals, and the health administration and the insurance. So all these are actors that could have a specific role within the SHAPES platform. We are in the process of creating those requirements that will be implemented in the next months. So this is just an example of this analysis that we're working on, or how we are collecting and analyzing the requirements through a detailed requirement matrix. Going back to the high-level view of the architecture, you can see there are several actors, as already mentioned. There is a need for standardization and interoperability so that those actors can integrate those solutions within the Shapes platform, which in trying to simplifying a little bit the approach so that it's basically understandable, the platform has a basic Shape secure cloud, centrally organized with a very strong security layer and with a set of tools and a knowledge base so that we can make big data analytics. There is also a Shape gateway that will allow to connect with third-party solution and also medical devices and other devices from the Shapes marketplace. This is more or less the architecture that we have conceived. As you see, we have the different actors, as mentioned, the 6 actors. We have a set of pilots that are going to happen. And then we define the central architecture, the security assessment as a service. So the security is very important in this central architecture. And we have 2 interoperability layers. One is the symbiote mediation framework that will allow us to connect with IoT devices and create a gateway to connect any other third-party solutions, and also internal components that will allow to between the different systems that will create this platform so that the information can be integrated uniquely. All this architecture is based on and trying to reuse what is happening across Europe concerning interoperability and standards. And as you can see, there is a long path of discussions at the European level concerning interoperability. There is a wide interoperability program that does not concern only healthcare, but also concerns other domains. And this is the European Interoperability Framework, and this is the conceptual model trying to address interoperability at least at 4 layers: the legal, the organizational, the semantic, and the technical. And the idea is to have a set of principles, interoperability principles, so that we can manage interoperability with a specific governance. Going in more detail and trying to see what the European Union has done in the several years concerning the digital health domain, the European Commission has focused mostly on implementing what has been called the digital single market and provides same type of services to all the European citizens across Europe. In healthcare, that's more or less translated into what we call the cross-border healthcare domain. And you can see that since 2008, several pilots and projects have been operational. And now we are in the phase that we have a set of digital service infrastructure that have been implemented at the European level. And there is an e-health DSI, one component that allows the information exchange between different institutions across Europe. For 2 scenarios for the moment, e-prescriptions and patient summaries. This was designed in a very large-scale project called EPSOS that lasted from 2008 to 2014. In that sense, there is a more detailed interoperability based on the European Interoperability Framework for Healthcare, which is called the Refined eHealth Interoperability Framework, which is based on 6 layers instead of 4, since healthcare is much more complex than other domains of public administration, by including the care process and other very important points. So the application layer and the infrastructure layer on the technical grounds need to be separated. In that sense, interoperability is very complex, and we have quite a lot of stakeholders that need to be engaged. A separate type of stakeholders need to be engaged at separate levels, and all this needs to be somehow organized so that we can manage at the end to have an a proper interoperability information exchange. In order to support the refined interoperability framework, the European Commission in 2015 has identified an announcement and a recommendation to all member states to adopt 27 Ihe profiles that can implement the specific use cases for interoperability that are included in the European e-health interoperability framework. So Ihe Profiles, Ihe stands for Integrating the Healthcare Enterprise. It's an entity, non-for-profit organization at a global level that meets the requirements from the user community and the vendor community and creates integration profile. That means that you can implement a specific use case of information exchange end-to-end. So those are just acronyms of specific profiles, but all the aggregation of all those integration profiles create a vast operational network of use cases that can be deployed at the European level. And this is what also the Shapes platform will assess and try to comply with. The healthcare domain and the interoperability information exchange is constantly evolving. So the European Commission has issued last year on 6th of February a new recommendation to move and to create an European electronic health record exchange format that will move and add to the patient summaries and e-prescriptions that already have been implemented based on the EPSOS projects and the e-health DSI, to include also laboratory reports, medical imaging reports, and hospital discharge reports, so that this can be exchanged through the same network in the upcoming years. For that to be able to be created, there is an ongoing project that will create those specifications that will be freely available to all member states. There are 34 participants across Europe that will develop and test those specifications. Those are based, as I said, on basic standards and integration profiles, covering mostly standards coming from HL7, which is an organization that is specialized on information exchange in healthcare. So currently, the European specifications use a standard called HL7 CDA, which stands for Clinical Document Architecture, and allows you to exchange standardized documents from one endpoint to another. In the future, there is a new standard that is being developed, which is called HL7 FHIR, and will allow the same information exchange of documents, but it will enable this to be exchanged by mobile applications, providing more flexibility and more new use cases, especially those that include the patient engagement, which is really the case, and it's very important for the Shapes project. Now, realizing interoperability and standardization is about teamwork. Everything starts by creating and applying the standards. The standards in interoperability need to be based on specific use cases, so that we identify the business needs that needs to be covered. Usually the vendors, they have their own community and they are making peer-to-peer testing of those specifications in events called connectathons that are happening globally 3 or 4 times a year. And in our case, what we want to perform and validate our quality and adherence to standards is that we should, as a project, implement and create a peer-to-peer testing with what we call a projectathon that will test the specific specifications and functional specifications that apply to the Shapes program. And this will allow all the participants, consortium members, and other third-party solutions to integrate and interoperate with the Shapes platform. As a conclusion, concerning this domain, the Shapes platform objectives are highly built on the use of standards and interoperability, so that's one of our main targets. The Shapes project will incorporate EU-related best practices in the domain and also align with the European Union refined e-health interoperability framework. And at the end of the project, Shapes intends to propose interoperability specification for integrated care and social care that could potentially be integrated and adopted by the standardization development organizations, especially in the domain of mobile internet, medical Internet of Things, and also integrated care and social care. I would like to thank you for your attention and goodbye.
Thank you very much for these last two presentations. This concludes our morning session. We will have a 10-minute break now. After that, I will give a short introduction to the 4 interactive workshops which will be hosted on the Zoom platform. So please be right back in 10 minutes. Thank you. Welcome back everyone, and thank you for staying with us today. I hope that you are now ready, inspired, and looking forward to the 4 interactive workshops that we prepared for you. For this, we divided you into 4 different groups. That way, each group can participate in each workshop topic. The workshops will be run in parallel and in 4 subsequent sessions. The workshop sessions, as well as the wrap-up, will be performed on the Zoom platform. Therefore, after this introduction, I want you to join the Zoom rooms. For this, we sent you access links via email. Please follow the instructions that we sent you via this email to always ensure that you engage in the right workshop at the right time. The workshop sessions will be 50 minutes long. After the first workshop, we will have a lunch break. After the other workshops, the breaks will be 15 minutes long. Please use those breaks to have some rest, as well as to find the next Zoom session. If there should be any technical difficulties from our side, we will let you know via email. In such a case, please check your email inboxes. For instance, we have a backup plan if Zoom should fail. Then we will send you links to an alternative platform to keep the sessions running. If you should encounter any difficulties or have questions throughout the day, please contact us via the email shapes@carusconsilium.de. This email address you find in the live comments right now on the right, as well as in the video description below. After concluding the workshop sessions, there will be a wrap-up on Zoom as well. In this wrap-up, we will summarize the results of the workshops and how the results will be processed to form the actions of shapes. So once again, thank you for joining us in this second dialogue workshop of shapes today. Your input is needed to ensure valid results of the project and for us to benefit from the wisdom of the crowd. So once again, thank you very much. Enjoy, contribute, and age smart and healthy.